operations in the time of COVID-19. I am Sara Fitzgerald, and I'm one of the pediatric diabetes nurses here at Midtown. And I've been here for about 7.5 years, and I recognize some of the names on the list. I know we've worked with you guys before. So we have a few objectives today. The learner will be able to apply the knowledge of the new technology in diabetes care with the students using the newer technology available. The learner will recognize psychosocial factors that impact glycemic control. The learner will express understanding of new research related to type 1 diabetes and COVID-19. I'm going to be your first presenter and just give you an update on what has happened over the last year besides the whole nice little pandemic that we've had. What is new? I'm going to go over the continuous glucose monitor updates, the insulin pump updates, the differences with the insulin delivery systems. We now have a generic kind of insulin and newer and faster rapid acting insulin and new ways to give glucagon. So the review of the CGMs, we know that most of the sensors are worn for 7 to 14 days. The Medtronic is like 3 to 7, and the Dexcom G6, which is very common, is worn for 10 days. There is a good chance that the G7 will be released by the end of this year. It's going to be basically the size of 2 nickels stacked up against each other. So it's going to be a lot smaller, and it's going to have potentially even a 10 to potentially 14-day wear. The Abbott Freestyle Libre, which was not really common in the last couple of years, but there's a new update on that one. And the Eversense CGM, you guys might not have seen, that's an implantable CGM that's only available for 18 and above. They have to basically change out the sensor every three months when it's implanted. The big news that came out in about August, summer, fall, was the Freestyle Libre 2. The original Freestyle Libre did not have alarms to alert if the child was low, so the only way you know what their blood sugar is by swiping. But with the Freestyle Libre, you get real-time alarms just like you do with the Dexcom. It does not connect in an app in the phone. They are still working on the FDA approval of that. The big thing with this one is it cannot take an excessive amount of vitamin C, like airborne, stuff like that, because that will conflict the numbers that they will see. The insulin pumps, we've had the Medtronic 630, and now we have the 770G, which came out in the early fall, and the Tandem T-Slim 2, and then it's been a little over about 18 months ago, like 2 years ago, the Omnipod Dash, and still we have the Omnipod Euros. We have some updates coming up, but I wanted to kind of get into more what we've seen over the last year. There's more automated insulin delivery systems. They're sometimes called an artificial pancreas or a hybrid closed loop. It basically takes the CGM, a smart algorithm, and also the pump, and with the smart algorithm and the CGM data, automatically adjusts the insulin delivery via pump. So you may not know that the particular patient is getting like their basals being decreased or increased, or that they're getting like a bolus in the pump because the pump's doing some of this automatic stuff. It's not completely to the point where we don't still need you guys, because you still have to enter carbs, you still have to put in your blood sugars. The main goal is to eliminate the low blood sugars, improve time in range, and reduce hyperglycemia. So the Tandem Control IQ came out for 14 and above, but it has now been approved for 6 years and above. Basically the big difference, again, is with the automated system, with the Control IQ, we're seeing about patients are spending 71% time in range, or in their range, target range, in 24 hours with the study. So it basically means like if they're sensing that the blood sugar is going to be 160, they'll increase the basal. If it's sensing it's going to be above 180 and nothing's been done, it'll actually give a correction bolus to correct. But there's different modes, like sleep mode won't do correction boluses if the patient's in sleep mode, and they can pre-program that. If they put it in exercise mode, that also can change up what they're with the different settings. I will be honest with you, what we've seen once they've gone to control IQ is in the practice, we've seen drops in A1Cs by a half point to like a whole percentage point. The Medtronic 770G was an upgrade of their 670G. It's approved for 2 years old. It only works with the Guardian sensor, but the sensor needs a calibration of 2 to 4 times a day. It is another like automated insulin delivery system, and it tries to help prevent the high blood sugars and try to prevent the low blood sugars by adjusting the insulin throughout the day. It automatically adjusts the basal insulin based on the target. There's an exercise setting in it, so to prevent the lows, and the machine is waterproof up to 12 feet for 24 hours. Be honest with you, do we want them jumping into a pool with the pup? Probably not. Coming up next is the Omnipod 5. And this will be the first patch tubeless pump that will be an automated insulin delivery system. And our kids can actually have it through an app in their phone. If they don't have a phone, it will still go to like a PDM. It basically you can adjust the targets between 110 to 150. It works it takes basically the Dexcom G6 with their algorithm and with their Omnipod system. What the big news with this is the time in range for adults and adolescents with their normal system of 65, went from normal before being automated from 65% to 74% more in range, time in range. In children, the time in range increased from 52% to 68%. Going on to another thing that's kind of been around, but it's kind of being used a little bit more, is the InPen. And this is basically another kind of pen device, but it works with an app in the phone that the patients can actually see the record of their last dose, the last injection. They're able to use the half units. It uses the Novolog, Humalog, and Fiasp cartridges so they can, and it's good for use for 7 years and above. It's shareable with the healthcare team, so we can actually get a download of their report and see how much insulin they're getting, how many carbs they're getting, what was their blood sugar, and all that. And it actually calculates the insulin doses out for the patient. So all the patient's doing compared to with the pump, with an insulin pump, is they're basically putting in the carbs. The InPen is saying they're putting in the carbs and the blood sugar, and the InPen saying, okay, we recommend you get 6.7 units. And they basically then have to just give 6.7 units on the InPen. So there's a couple things that have changed. Generic insulin. Lilly and Novo Nordisk, who make Humalog and Novolog, they have basically come up with a generic insulin or unbranded biologic. Basically, all the difference is it does not have Humalog's name on it or Novolog's name on it. It only has Lispro. And it's the same formulation like the Lispro is the same formulation as Humalog. The Aspart is the same formulation of Novolog. It just doesn't have the brand name, and it's cheaper for the patients in a sense. The other thing that that's kind of been around getting popularity is Fiasp. It has it's a faster onset. It's in and out of the system faster. It's an ultra wrapping. So acting insulin. So it basically, the onset is within 2.5 minutes. It can be taken up to 20 minutes after the meal. So if we're giving it after the meal, they'll still get that quicker onset compared to Novolog. The big difference is they took Novolog and added vitamin B3 to it to make it faster. Lyumjev is another one, is Humalog's or Lilly's faster ultra rapid insulin. Again, they only added the vitamin B3, and compared to Humalog, it helps decrease the spike 1 to 2 hours post the meal. The two types of new glucagon is we have Baqsimi. It's a nasal glucagon. It can be used even if they've got a nasal congestion. And we have also Gvoke, which it can be in a pre-filled injection or basically a hypopen, kind of like your EpiPens. The benefit to these is there's no mixing of the powder and the liquid, which kind of can honestly, in that emergency situation, can cause a lot of frustration. And when you're even showing it when there's no emergency, parents do get a little like worried about it. And when you've got maybe siblings in the home with the patient that they're babysitting, maybe giving the Baqsimi is easier for, say, their brother or sister to give, or grandma, grandpa. The Gvoke HypoPen, kind of good for coaches because it's kind of just like the EpiPen, so that they can kind of give it and it will act the same. The same thing as with the glucagon, you have to roll them on their side. Also call 911 because they will vomit potentially from the sugar rush of the glucagon. Now on to Jennifer Anisko.
Thank you, Sarah, and you'll be doing our slides for us. Thank you. Okay, I'm Jennifer Anisko. I'm a nurse practitioner here at University of Maryland. I'll be celebrating my 20th anniversary as an employee of University of Maryland, and I've been with the Diabetes Center since 2007. Yeah, so I've been around for a little while. So I'm going to take the next few minutes to talk about the psychosocial considerations in diabetes management and highlight psychosocial factors that impact glycemic control. So many families with diabetes say they do something one day and it works great, it works beautiful, but when they repeat or replicate or do the same exact thing the next day, and you might have this experience too in school nursing, they get a completely different outcome in terms of blood sugar. So this highlights the fact that diabetes management is not an exact science, but more of an art, and that there are so many variables, including psychosocial factors, that must be considered. So complex environmental, social, behavioral, and emotional considerations make up the psychosocial factors that influence living with diabetes. And identifying the problems, screening, and diagnostic evaluation in those areas will help optimize health outcomes. And to prepare for this presentation, I referred heavily to the Psychosocial Care of People with Diabetes position statement of the ADA, which was published in Diabetes Care 2016. Okay, next slide. So I'm going to break it down into the following topics. First, I'll talk about the child who is newly diagnosed with diabetes. Then I'll talk about considerations in different age groups. I'll talk about diabetes distress and family social determinants of health, briefly talk about the impact of COVID-19 pandemic on this population, and then talk about assessment tools and common psychological comorbidities that have social, behavioral, and emotional impact, and conclude with some support strategies. Next slide. So the diagnosis of any serious chronic medical condition is stressful for the whole family. Usually there's a range of emotions, initially shock and grief. We see grief expressed in different ways, including anger and sadness and despair, anxiety and guilt. Both positive and negative emotions and stress can affect blood glucose levels. The child and family are sad and missing the way things used to be before the diabetes. Mealtime is stressful, birthday parties, holidays, eating out, sports, activities can't be spontaneous anymore, and that's stressful. And even in young ages, children realize the difference between themselves versus their siblings, friends, and peers that don't have diabetes. And parents sometimes feel guilty that they let this happen, or they somehow feel like it's their fault, or it's something they did wrong, or could have done differently to prevent the diagnosis from happening. There's fear and anxiety and distress in parents when they're releasing their child into the custody of somebody else's care, whether it be daycare, the school, or grandparents. And all of this is stressful and anxiety provoking, which affects mental health. Next slide. So children at different ages are at different developmental stages. I believe school staff are experts in this concept. There are different behavioral expectations at the different stages. Elementary school students need adult supervision with diabetes tasks, but should work towards the goals of having the child recognize and verbalize symptoms of low blood sugar and high blood sugar, and becoming cooperative with the diabetes tasks. Middle school students are capable of completing the tasks, but still need supervision and reminding. And the preteen and tween age, they are starting that shift in priorities and feeling the power of the peer group and the self-image concerns and possibly privacy about their diabetes. Next slide. Okay, so now the teenager. We know adolescence is challenging. They want more autonomy and independence. There should be an appropriate balance between adult supervision and independent self-care, and the balance is dynamic and evolves as they are emerging young adults. So they wish to fit in with their peers and with the group, and they may hide or minimize their diabetes for privacy or self-image sake, which compromises management, and they engage in risky behaviors as they are influenced by their peers or are testing boundaries, which compromises their health. There is less interest in the future and more emphasis on instant gratification rather than delayed gratification. And all of this is compounded with the physiological changes happening from puberty, which causes insulin resistance, AKA hyperglycemia. So I purposefully chose this image of an iceberg to represent the teenager because what appears on the outside first glance, or what the teenager decides to share with the public, is just the tip of the iceberg. Maybe you're lucky enough to be allowed and trusted to see what lies below under the water surface. So remember, though, that suboptimal glycemic management should not automatically be attributed to adolescent rebellion or lack of concern for their health. About a third of adolescents develop diabetes distress. Next slide. So what is diabetes distress? It is very common and it's distinct from a psychological disorder. Diabetes distress comes from the constant burdens of diabetes treatment. What burdens? Calculating medication, giving medication, adjusting medication, monitoring glucose levels, and monitoring food intake and eating patterns, and monitoring physical activity. It's all physically and mentally draining. It means worrying about the adverse consequences and progression to complications like neuropathy and retinopathy. So this sense of burden or defeat is common in people with diabetes, and as mentioned before, especially in parents taking care of their children with diabetes. So when diabetes distress is identified, we try to adjust the treatment plan or address the family education to decrease that sense of burden before it gets worse. And how can we simplify things? And how do we help with problem-solving skills? So naturally, diabetes distress is an expected emotional response in the time of COVID because all reports point to diabetes as a risk factor for poor outcomes with the virus. Next slide. So even when you feel like you may know a whole lot about diabetes management, it's not going to help very much if you don't know your families, and a plan is only effective if the family can implement this plan. So family involvement is a vital component of optimal diabetes management, and families come in different shapes and sizes: single parents, grandparents raising grandkids, blended families, split custody. Again, it's the image of the iceberg. You have to get underneath the surface. A parent is not going to be able to maintain their child's optimal diabetes management if they're worried about food insecurity or money for rent or mortgage, or if there's other financial debt they're worried about, student loans, credit cards. Health literacy, just like knowing simple things like how to get insurance and how to get prescriptions, health numeracy. Like we can't give someone a complicated insulin dosing regimen if the health numeracy is not there. So when there's family-centered care, health disparity barriers are more likely to be overcome. Next slide. So enter COVID-19. So highlighting the psychosocial factors again, environmental, social, behavioral, emotional, and then we add COVID-19 pandemic, quarantine, virtual learning, social distancing experience we've had over the last year. My colleague Malinda Duke will answer questions about the impact of COVID-19, but I'd like to highlight a couple of things in reference to mental health. There's many adversities and challenges that we've experienced in the age of COVID. Many have felt or have been worried about social isolation, drastic changes in schedule, routine or lack thereof, changes in the amount of family support and adult supervision, and the fear of complications when you compound diabetes with COVID. And all these challenges, no doubt, impact the psychosocial factors. There was a study conducted in Italy, published in the Journal of Eating Disorders in December 2020, that compared children and adolescents with T1D with a cohort without type 1 diabetes. And both cohorts were quarantined at home to see if there was more disordered eating behaviors in the type 1 diabetes cohort. Results revealed actually that there was not more disordered eating in the type 1 cohort, but that there was more, it was more a female adolescent developmental issue. There was another Italian study published in July 2020 in the Frontiers in Pediatrics, and that reported that in 204 pediatric patients aged 5 to 18 with type 1 diabetes, they were given a questionnaire to investigate behavioral responses during quarantine. And even with quarantine being a stressful psychological condition, living condition, results showed that more children and adolescents developed high levels of resilience and excellent coping skills by using technology in a proper way. So when technology is available, children and adolescents have been able to continue social learning, school learning, and ensure social networks and minimize negative emotions related to social isolation. So COVID has affected some people minimally and so others drastically. Some children have been resilient and some have not had as great success. The ADA published guidance as part of their Safe at School resource, and my colleague Amanda will also reference this. The recommendations include addressing the fears, providing medical facts, demonstrating ways to minimize COVID-19 exposure, adapting 504 plans and IEPs, and promoting social interaction in a health conscious way. Okay, next slide. So here I've included some assessment and diagnostic tools that we often use. So screening for psychosocial distress or mental health problems like depression, anxiety, and eating disorders. So screening early can help minimize adverse effects on diabetes management and outcomes. So here are a few validated screening tools that we use, and there are others. For diabetes-related distress, the PAID survey, so that's problem areas of diabetes, it's 20 questions, and there are different versions validated for children, teens, and parents. And then we also use the PHQ-9 modified for teens to screen for depression in our patients 12 years and over. And then there's also an anxiety screening tool. Keep in mind the total score on the screening tool shouldn't be used necessarily to diagnose a psychological condition, but to identify who needs a referral to a mental health care specialist. Okay, and then moving on to the next slide. Depression is found to be more common in children and teens with diabetes. Approximately 14 to 33% of teens with type 1 diabetes experience depression, and about 14% of teens with type 2 diabetes. And the PHQ-9 screening tool asks questions about changes in sleep, appetite, weight, energy level, concentration, school performance. It asks about feelings of guilt, irritability, anger, sadness, hopelessness. Has there been a lack of pleasure in things previously enjoyed or disengaging in social activities? And then anxiety is also prevalent in this population and manifests in different ways, including worrying about complications, needle phobia, or worrying about injections, taking medications. Fear of hypoglycemia is a big anxiety provoker. If you see avoidance behavior, excessive repetitive behavior, or social withdrawal, there could be problems with generalized anxiety disorder, body dysmorphic disorder, OCD, specific phobias, panic disorder, or PTSD. So again, screening earlier helps decrease adverse effects. Next slide. And then youth with type 1 diabetes have an increased risk of disordered eating behavior. Females with type 1 diabetes are 2.5 times more likely to develop an eating disorder compared to their peers. Intentional insulin omission appears to increase with age, with highest rates in middle adolescence and young adulthood. And the causes of eating disorders are both genetic and environmental. There's an increased risk with depression and anxiety. And with standard treatment of diabetes care, which calls for counting carbs, measuring food, monitoring blood sugars, all these actions, when they're like focused on or obsessed over, they can trigger a eating disorder mindset or disordered eating mindset. So the screening tool that is used is the Diabetes Eating Problem Survey. We start that screening around age 10 to 12. Okay, next slide. So you as a school staff are on the front lines, and you may be able to pick up on the psychosocial risk factors quicker than the diabetes provider if you're seeing them more often than we are. So when do you need to refer to a trained mental health professional? So when there's a serious mental health issue suspected, positive screen for depressive symptoms or anxiety, or presence of symptoms of disordered eating, or intentional omission of insulin to cause weight loss. And then we also refer when youth and families with behavioral self difficulties have repeated hospitalizations, like for DKA or significant distress. So support strategies. So remember, children of different ages are able to do different tasks and accept different responsibilities when developmentally appropriate. And it is important not to expect more from children than they are able to do. If they are unable to do the tasks, they may develop poor self-esteem, resulting in poor self-care. So we need to avoid premature transfer of diabetes care to the child who is not ready. And there should always be personalized care and shared decision-making about healthcare, which improves self-efficacy and empowerment. And then finally, in conclusion, next slide, sorry. So the support village is vast: school health, guidance counselors, social workers, community health workers, DSS, CPS, family preservation when necessary, diabetes camps, support groups through JDRF, children with diabetes and ADA can provide peer support. So just again, please remember to consider family dynamics and developmental stages. Psychosocial support begins at diagnosis and continues to in a developmentally appropriate format. And personalized diabetes management is critical to minimize barriers to care and maximizes responses to treatment. So there are rapid, dynamic, cognitive, developmental, and emotional changes occurring during childhood, adolescence, and emerging adulthood. Add the challenges of diabetes management onto that, and then add the substantial challenges and changes that the COVID-19 pandemic brought on top of that. I will turn it over now to Malinda.
Hi, good afternoon. I'm Malinda Duke. I'm in my 25th year with University of Maryland Center for Diabetes, and it's a pleasure. I'd like to thank the organizers for the invitation, especially my good friend Barbara Matsoulis and my new friend Kathleen. This session will hopefully be a bridge or a tie together of some of the previous speakers and present some research about what's been going on in this pandemic and unprecedented, yes, I did say it, year. And this is, we can go into the next slide. So question, and I set this up in 5 questions-ish. The first question is, has COVID-19 delayed the diagnosis or worsened the presentation of type 1 in children? It's a 3-part answer. In the early and mid-spring data, yes, everyone was on staying at home. They were listening to what things were happening. We were doing telemedicine. We were doing our very, very best to keep everyone home of the known diabetics. Of the parents that were listening to the news, they didn't want to take their children into the emergency room. So in fact, yes, the early data showed that there were 23% less cases worldwide. And when they did present, about close to half of them were in DKA. So they were holding on to their kids until they saw that they really were having some problems. By mid-spring, the data continued to show that there was some delay in diagnosis, but some other things were sort of contributing to that. The Italians kept great reviews. They have a super good registry. And by about the mid part of May, they were able to look at UK data, India data, USA data. 2,300 healthcare providers were solicited answers from 75 countries. And they did see that there was an increase in DKA. And then we started seeing that some of these patients were coming in as either positive COVID or having COVID antibodies. In most of those cases, there was another family member that was also COVID positive. But in that same research, very few kids were very, very sick. Only 5 were in the ICU. 2 of them with type 2 were intubated, but there were no deaths. So they started to reevaluate, and the current status we'll go into was, I will share in next slide, but I want you to notice what our particular stats were, that we had 82 new onset diagnoses in 2020, which was a record for us, and it's not letting up, 31 by present. So the conclusions at about midway through, that there were some delays for fears of catching something else if they brought their child to the hospital. Next slide. So are children and youth at increased risk for hospitalization? Here was a great study. The bottom line being, keep calm. Kids under 20, people under 25 with diabetes were not hospitalized. And 4 of the countries of the 3,000 total patients, I've highlighted the top ones, and you can see that they were not necessarily having large amounts of COVID as they started, and very few were hospitalized. But data presented at the Endo Conference 2020, just in last month in March, results had 3,000 type 1s that were positive compared with 50,000 that did not. And so there were no significant rates of mortality, intubation, sepsis, as long as the A1C levels were below 7.5%. It was significant risk if the A1C level was above 9%, and it exponentially rose. Next slide. So who is at risk? Well, we certainly know about the mental health burdens, but they're actually those patients that were in poor metabolic control, those patients that had obesity, comorbidities, cardiovascular in particular, and pulmonary. Vitamin D deficiency was found to be at risk factor, and infants. What was an impact from COVID? Well, there were some supply chain issues for test strips and insulin worldwide that was really a huge theme, but also inability to get healthy food, people not being able or feeling uncomfortable seeking medical care and advice, and the quarantine, isolation, mental health issues that I've said before. Next slide. So what are the clinical characteristics? So when you have poor metabolic control, you release a lot of tissue injury-related enzymes. You have uncontrolled inflammation response, hypercoagulability, we're going to come back to this in a little while, dysregulation of your glucose metabolism. So even though we've said that the highest risk were those kids that were under 7.5, the reality being that only half of kids can really achieve an A1C goal under 7.5. Those kids that have high levels of obesity were very vulnerable and made worse by the pandemic. The ISPED was the International Society of Pediatric and Adolescent, and they said that the best thing that we can do is reassure patients and families that care is available, that we can maintain, we try to get the families to do their very, very best in good metabolic control. In our practice, we reached out and we did a lot of telephone, and we did a lot of other ways to communicate and make sure, and that's where technology went in. Increase the frequency of these visits or in-person visits if necessary. Promote healthy nutrition, avoid excessive calories. ACE inhibitors needed to have a special consideration because in some cases that actually made things worse, and regular physical activity. Next slide. So what's happened? I think that this was a very good study that was done in Israel, and it looked at a 4-week study of 650 patients, and they wanted to get very specific data. So they wanted people that used CGM data at least 80% of the time. And so the number dropped to 102, but they found that there were increases in caloric dense food, increases in eating out of boredom, decreased opportunity for exercise. People were staying home because they were afraid, extended sedentary activity and screen time, which I know you guys know that the kids, even going back to school, that's still a lot of screen time. Irregular sleep patterns. I myself and all of our practice has heard about kids staying up half the night or most of the night and then getting up, checking in for school, but then they're tired, so they check out of school. Increased anxiety about COVID itself. They were worried about getting it and what would happen. And reports worldwide were that they were afraid that the standard of care that they normally received for an inpatient visit was not the same as a telemedicine visit, because A1Cs weren't able to be checked, and if patients didn't have any kind of technology, then it was more difficult to get real and true guidance. It was more pronounced in children under 10 and in the lower socioeconomic kids. Question 4B, what are the effects that we've seen? Well, I did a quality control study. Remember, you may know that we have 6 providers. So this is just a little smidgen, and you can replicate that. Sorry, 5. Sarah. It's a 1-year retrospective data. They were included if I actually saw them in just before COVID, January, February, and exactly a year later. They were excluded if they were still in honeymoon, and they were divided into 3 groups. The target group, the slightly above, well, the above target group, but not in a bad place, and the uncontrolled above 9.5 in that 9.6 and way above. So these were my numbers. And as you can see that there were some that kind of moved in and out of certain groups. I was really fascinated by the fact of the uncontrolled group. 6 were on pumps, 7 were injectors, but only 23%, 3, used CGMs. And when I looked at that, there were at least 3 of those patients that could have been on CGMs but chose to stop. In the above target group, 94% of those kids initially had CGMs and were using them. And that's where we can see that the above target moved into target, which pleased me. Of the target group, 27 were on pumps, 7 were injectors, and 88% were using CGMs. My original postulate was that the uncontrolled kids in my practice probably didn't do any better being at home, away from the school nurses, away from the structure that they were used to, away from having somebody at least monitor them for a good portion of most school days. And as you can see, that was at least true. Next slide. So I wanted to do a little bit about vaccines. I do not pretend to be a virologist, but I certainly have done my due diligence in learning about this. And I'm going to do a review of what's going on. Next slide. So there's a great tutorial, and I put the site here, on how vaccines work. And the most important thing for you to realize is that when the vaccine is delivered, that it's an antigen presenting cell that T cells then talk to naive B cells, and antibodies are produced, and that's going to then come around and help us, our bodies, to fight off disease. We also create memory cells so that they can be reactivated at a later time. Next slide. So what are the current vaccines? So the FDA has presented us 3 choices under the Emergency Use Authorization Act. Pfizer is available for 16 and above, and it's an mRNA type vaccine. We're going to go into that in a little bit. 2 shots, 21 days apart. Moderna is 18 and above. It's also an mRNA shot, and it is 1 month apart, or 28 days. And the Johnson & Johnson vaccine is a single shot, a one and done, but out of an abundance of caution, the Johnson & Johnson is currently on pause. So can we look at the next couple of slides to get a little bit of looking? I want you to try and understand this rather complicated slide by, instead of starting from the sides and moving inward, to start in the center of an immune response. We get there in 2 different ways. On the left, we have a vector vaccine. The vector vaccines are traditional vaccines. They involve an injection with an antigen, such as a purified protein, a polysaccharide, and it uses, in the case of the COVID, it uses the adenovirus as the vector. Coincidentally, this is also the AstraZeneca way of using things, and AstraZeneca has also been noted to have some leak syndrome and blood clot issues. But I'd like you to notice that it's the DNA that then comes down, and the messenger RNA is then talking into the ribosome processing, which then creates a antigen to the corona spike protein. With the mRNA, we can actually get a blueprint for the antigen for the specific coronavirus COVID A, and it synthesizes this protein and it uses to attack to human cells. So what it does is that the COVID mRNA vaccine is given in the upper arm muscle. It goes into the muscle and it stays on the outside of the cell. It never goes into the nucleus, and it makes a protein piece. After that protein piece is broken down, then it goes to our lymph nodes as memory, but it can also talk to the ribosome processing unit and create that antigen, so that the spike proteins that are really what are so dangerous in the lung are created and have memory. Next pictures. So here are some SARS-CoV vaccine, COVID that are infecting a cell. Next one. These are very cool photos I found. Here's our cell with like a lung cell that actually has the SARS sitting on it, and you can tell how sticky it really is. That spike protein, the spikes on the outside of the COVID are the things that sort of attach to the cells. And then last but not least, we have a picture, move forward, of the T cells, which is what we're trying to produce, that can fend off the variants as well as the original one. So let's go on to the next slide. So question 5. Anybody had any thoughts to why children have shown greater protection against COVID? Because it's been the older people, it has been the people with obesity, with type 2, but our younger folks have actually been remarkably well. So there are several really interesting hypotheses, and they have to do with heterologous immunity or cross immunogenicity. Say that 3 times fast. But you need to know a couple of things about kids that are really, really interesting. There are some non-specific effects of vaccines that are more pronounced in girls and maximized at 6 months of life. Now, that's when the maternal hormone, the maternal coverage is weaning off, but we started other vaccines. But since other vaccines, our MMRs, our DPTs, all of those other things have some cross immunogenicity, and because kids just recently were vaccinated, there's some thoughts to that that it's helped kids in this era to be less sick, have, even though they may be positive, they have less illness. Another thought is that the role of memory T cells, we talked about the memory T cells a little bit. So children have more naive T cells to be programmed. They don't have a exaggerated immune response. So if there's a less exaggerated immune response, then unlike adults that are mounting this vigorous trying to respond, and those are the ones that have gotten very, very sick, there's less of a cell-mediated attack on the lung or the interstitial tissue in the lung. Most childhood vaccines stimulate T helper cells. So is there crossover with the T helper cell? A great example is if you inject MMR vaccine into HPV warts, they actually get better. So there's a lot of viral crossovers that are happening. There's another group that was looking at the BCG vaccine. That wasn't one that I was even familiar with. It is given in infants to prevent severe forms of tuberculosis. And there's some countries that give it, and there's some countries that do not. And so an original study looked at the countries that had that as a mandate and the countries that did not. And it was certainly very clear that the kids that had gotten the BCG vaccine fared better. The infants did. So it was protective. They considered it a trained immunity. And so I thought that was kind of an exciting thing. They went back and they looked at 28 countries. Japan is one that has done this BCG vaccine since 1947. Iran since 1984. And they were able to do a comparison of the older people that would not have gotten the vaccine versus the younger people that did. And the people that got the vaccine, it actually was a strong correlation, not necessarily causality, but it was enough for us to look at what do the other vaccines help us with. The SARS and the rubella and MMR actually share 29% of an amino acid sequence. So it kind of makes sense that some of these things can cross over. In terms of the Hep A, I found this one very interesting. Children don't get that vaccine until they're 1 year of age. If you remember in the very early stages, there was a Japanese cruise line that was stuck and they wouldn't let the passengers off. And when they finally did, even though it was early testing stages, lots of those cruise line folks were positive for COVID, but a lot of them were not immediately ill or had symptoms. And the interesting piece with that is that the cruise line had told the passengers prior to them taking that cruise to be if they had never had or re-vaccinated for Hep A. So they all were a recent Hep A vaccine experiencers, and there is some thought that there's crossover there. Next slide. So what's coming and when? Since I've just said to you that most children are not at risk for severe illness, then why the heck are we going to sort of promote that children get vaccine? And it's called immunobridging. So Pfizer's been doing some studies and released some things just recently on their adolescents. And they're doing some children now in the 2 to 12 group. We expect that the teens are going to be ready for vaccines in the August to September time. Moderna has done 3,000 participants. They're just about finished their trial, And they likewise expect that the teenagers will be ready by fall. They also are in the midst of doing the 2 to 12-year-olds. Johnson & Johnson had, up until when I created this, had expected to continue. I think that this is on pause. They're taking a look at what's going on. But interestingly, I found, and as this Israeli experience, without approval of their medical board, they looked at 600, they chose to give 600 of their children with underlying conditions like cystic fibrosis, the Pfizer vaccine, and there were no serious side effects, and minor side effects were rare. Keep going. So I'd like to handle the next and the final part of our program over to Amanda Palmer, and we all look forward to your questions at the end.
Thank you. My name is Amanda Palmer. I have been a nurse at the University of Maryland Center for Diabetes and Endocrinology for about 1.5 years now. I am also in my 11th year as a parent of a child with diabetes. So that's kind of where the long-term diabetes experience comes from with me. So I'm kind of going to handle the aspect of just, we know you guys have a lot of questions, not necessarily COVID related, but just questions that have come up in general. So kind of wanted to help tackle some of those. So one question we get is what happens if there aren't 3 hours between meals? I feel like this year it's been an extra bit of fun because kids have had their home schedules, which have been just all over the place since they can eat while they're in virtual class. So then they come back and we're trying to figure out how we can get them their insulin coverage. So we have it kind of, if you look at it, if the student did, so say they ate breakfast, got some insulin there, or if the parent just gave them blood sugar coverage, but sent them to school to get breakfast there, you would give them coverage for their school breakfast carbs, not so much their blood sugar. Then for lunch, you would give blood sugar and carb coverage. If it's kind of the flip situation where they didn't get their insulin at home, so the parent just kind of wakes up, gets them on out the door, you want to go ahead and give them blood sugar and carb coverage at breakfast time, and then at lunch you would just cover their carbs. So always kind of keep in mind that 3 hour window. Handling a blood sugar that's high after a meal, we're not big fans of checking soon after meals just because we know that blood sugars will be higher. It's easier to see when you have a Dexcom rather than if you're just relying on finger sticks. But again, it's that 3 hours that we want to make sure we're hanging on to. So if your student has like an 11:30 lunchtime and they're kind of high at that point, we have every reason to think that an hour and a half later, if they have to get checked for PE or something, that they're still going to be high. So you can always encourage them to drink water. That definitely helps bring the blood sugar down. And then if you have a chance, 3 hours later and they're still at school, you could do a correction at that point. A big one we get is, can I really trust the Dexcom? And absolutely, we say yes. We know there's going to be more of a learning curve kind of for everyone, especially the patient, the student, and their families when they first start wearing the Dexcom. But we find that on the whole, they really work so well. We don't expect that there's going to be an exact match with whatever the Dexcom says and what they see on the glucometer, just as if you used the glucometer, same one, and checked it more than once, you're not going to get identical readings in all likelihood. And certainly if you use your school glucometer and the student's glucometer, you're going to likely get mismatches there. We just understand that there is some of the discrepancies. So all of the CGM companies do advise doing a finger stick if the Dexcom reading doesn't match the symptoms. So if the Dexcom showing, all right, this kid is 45 and the kid feels fine. Sometimes you just feel fine at 45, but in that case, you would definitely be warranted to do a finger stick just to make sure it looks like it's about in that zone. One case where we would say definitely also consider doing finger sticks is if you have a child with a persistent low. So they come in, they're low, you treat it, you give them their 15 minutes or so, and they're just, you know, you have to retreat it because they still haven't come up. So if it's, sometimes you'll get those Dexcoms where it just hangs out low. And that in that case, you do want to do a finger stick because sometimes the Dexcom kind of is sluggish to recover from some of those real stubborn lows. So you may see that the blood sugar has come up by that point. But overall, absolutely, we are Team Dexcom, Team Libre, whatever, if for helping understand what those trends are. And I think this one we're seeing a lot more just because there is so much more, there's so many more insulin types available right now. We often have no idea which insulin our patients are actually going to get, because maybe we order Novolog, but then their insurance covers Aspart, the pharmacy knows that all happens fine. We don't have any real concerns for the most part if there's you know, a different, you know, whether it's a generic or they just needed a different insulin because of insurance purposes. Most of the insulin branding, you know, whichever insulin our patients, your students end up with is just by and large has to do with what insurance preference is. And we do have the box that you can see here that's on the school form where it allows for substitution of any of the rapid acting insulins. All right. One question we get a good bit for our students who have insulin pumps, especially those who are kind of newer to them, is a question about this IOB. So what is IOB, or sometimes it's called active insulin? So that stands for insulin on board. You know, like you learn about when you learn insulin, about insulin stacking. You can't have, you know, insulin any sooner than every 3 hours or so. This is a great feature of the pump that shows how much insulin is still active in the body. It's gonna, so there's a setting in the pump that for most of them, there's one exception and we can talk about that, but most of the time we'll set it 3 hours, 4 hours, something like that. So the pump keeps track of, all right, if we gave this insulin, say it's a 3 hour duration, we give 3 units of insulin at 8 o'clock. The pump's going to know at 9 o'clock, there's 2 units still active in the body. At 10 o'clock, there's 1 unit still active in the body. So it's going to keep up with that. The insulin has already been given. So that's, I think, one place where people get really confused is they think that it's taking 3 hours for the insulin to be delivered. That's not the case. The insulin all goes in within a couple of minutes of pushing go on the pump. It's just the pump's keeping track of how much is active in the body. And it will use that in dose calculations that you might have to call for, you know, say if it is one of those cases where you're looking to give a snack or something 2 hours later, it'll keep track of how much of that insulin from that last dose is still active. You can see where the arrows are pointing. This is the tandem T-Slim pump on the left and the Omnipod Dash PDM on the right. Both of them on the home screen do show you how much insulin is still active for the child. So how do I see how much insulin was given? This is a big question, particularly when you have a student who can push their own buttons in their pump or who allowed or not. You're able to go into the pump to see how much insulin was given, when it was given, all the particulars of the dosing. It'll tell you, you know, how many carbs were covered for. If a blood sugar was put in at the time, it'll give you that information. Again, this is the tandem pump. You basically, for anything you're going to do with the tandem pump, just about, you're going to hit the options button, go down, and you can kind of see it listed here, but you're going to go into the pump history, and you can look for if it was given a bolus, how much insulin have they gotten through the day, that kind of thing. So that one is for the tandem pump. Next is the Omnipod Dash pump. It does handily show right there on the screen how much the last bolus was. and how much the last blood sugar was when you entered to get a dose. You can also go into the pod info section to see if you need to go back further in the history. Much like with our documentation in nursing, if it is not in that pump, it didn't happen, except truly, if it's not there, it didn't happen. A lot of times, people will swear up and down, oh, I gave it. It may be that they just didn't. There are a lot of safety features in pumps so that you don't accidentally give insulin. It may be that they got all the way to that last screen and got distracted before they hit the final, yes, I'm sure I want to give this amount of insulin. So if you don't see it listed in there, they did not get the insulin. All right. And then just kind of ending my little bit with some more resources for diabetes and COVID. The American Diabetes Association has, they already have really great Safe at School resources on their website anyway. They have a great Safe at School program that they have all about trying to help families understand how kids can go to school and thrive with diabetes. They've added this great section about COVID related topics. So everything for recommendations on returning to school, recommendations for how to, strategies for virtual learning, recommendations for going to school during a pandemic, and the mental health considerations that come into play there, which touched on Jen's part. Recommendations, and I think a lot of you guys may be in the 504 section of getting things done right now. So recommendations for 504 plans with COVID in mind. And then also there's a great little PDF on there about rights for school employees during COVID. So I think most every school nurse I've ever dealt with has had employees who have diabetes, other staffers there. So whether it's for them or somebody else, just people with diabetes working at school and what their rights may be. And that, I believe, is pretty much what we have. We thank you guys all so much for what you do. We knew before, and it reinforced to us during the time when kids were out of school, that they need you. We have so much appreciation for all that you guys do. So thank you so much, and let us know, let our colleagues know what we can do to help support you.
So because we're running late on time, if you don't mind, I'd like to jump into some of the questions that we have. As you can imagine, we have kind of a bundle of questions about the pumps. First question is, how can we encourage our families to secure funding for the pumps, particularly in the school-based health clinic? We are serving people that are of lower socioeconomic. So what can we do to dovetail them into funding to get these pumps?
So if they're on any of the Maryland Medicaids, I'll be honest with you, the Maryland Medicaids pretty much by and by do cover them very nicely. It's my commercial, my families that have commercial insurance that kind of get into some of the more cost of getting the supplies and everything, because the Medicaids in Maryland cover those supplies.
Well, that's good to know. Okay, so what clinical data do you use to support a student's transition into the CGM model?
I'll be honest with you, we've been putting, I think this past year, we've been putting everybody on the CGM. If not within the first week or first 2 weeks, they've had it within the first month. I think the latest that family had to wait in the last year has been maybe 2 months. And that was because we seriously could not figure out what this insurance or where they would get it from.
Okay, so help us with this scenario. A kid comes in, got his sensor knocked off, fighting on the schoolyard. How do we deal with a knocked off sensor?
You go back to the old fashioned way. You check the blood sugars.
Okay.
And if you can contact the family and see if they want to come in and replace it. They may just decide to replace it when the kid gets home.
Okay.
But go back to the old fashioned way and check blood sugars.
Okay.
I would jump in real quick and add to that, if it gets knocked off at school, save it and send it home. There's a piece in there that they have to have, that they have to reuse.
Okay,
If
good
it
to
gets
know.
Mm-hmm.
thrown away, they are out of the Dexcom for potentially 2 or 3 more months.
Now, we had another question about a provider who has a new student with a tandem T-Slim control IQ, and where can this provider go to get additional information about how it operates so she can help this student in school?
I'll be honest with you, if you go into your smartphone, like your cell phone, your smartphones, the T-Slim actually has the T-Simulator. It's the Tandem T-Simulator app, and it's got it in the modes of their control IQ, their basal IQ. You can literally go into it and see all, yep, Amanda's showing the screen. You can literally see the screen and actually play and press the buttons.
Nice. Okay. Another question is, so many of our school health room documents require that we document blood sugars. So obviously it's easy enough if we have the old-fashioned strips, but with these more automated systems, particularly the closed loop systems, how do we get that data?
You're going to still see with the closed loop systems, you're going to see the Dexcom number or the CGM number. They can still provide that number.
Okay, great. How do parents encourage self-care of their children who do have diabetes, obviously within a developmental context, without becoming helicopter parents? How do we help the parents manage that kind of transition?
Baby steps. Yeah,
Yeah.
pick and choose your battles.
Right.
I mean, I sometimes say I'm not against bribery. There's the behavioral modification plans to start, but then if it's deeper than that, if there's more issues going on, then obviously some mental health counseling might be needed. But baby steps, bribery, or the official term of behavioral mental health, behavioral modification. So
Sorry, didn't mean to interrupt. For the participants, there is a link in the chat for Menti. If you want to, or those are the results, Barb, that people have noted. But we do have one more question that I'd like to get to before we let you go. Let me see. What are the indications for advancing someone to the super rapid insulins? Like why would we use that versus something else?
Malinda, telling you, Sam.
Okay, several reasons. Many kids that are very, very active, if they're using slower insulins, then that insulin is still on board when they want to turn around and then go have a soccer game or something later. So the IOB time, that time that the insulin goes in is faster, but the time that the insulin goes out is faster.
Oh, gotcha.
So for kids with very high activity needs, it actually works to their advantage so that you can pair the food and the insulin closer together, and then they're back to their basal rate without having worries of going severely low during activity.
Any of the newer insulins stable at room temperature, they still need all to be refrigerated?
Well, none of the insulins are, if you can keep them out for just a month, can be room temperature.
Got it. Okay.
Keep them in the refrigerator for length of time. So if somebody got a delivery of 9 vials, you keep the other 8 in the refrigerator because you don't want it out more than a month.
Got it. And then we're seeing an incidence, of obesity rise, particularly in the high school and even in the elementary school population. Can you just give a flavor for the incidence of TD2 in children now? It used to be if they were young, it was all TD1, but with metabolic syndrome and obesity, we're seeing signs of metabolic syndrome, and I'm thinking TD.
And we're very concerned about that because we're seeing them late. The reality is that both the pediatricians and the schools have a obligation to pick out these kids, in my opinion, by age 5, so that we can do some early prevention. But you know, in many cases, prevention isn't paid for. Those kids that are looking like they are falling off the curve by rising too fast would really